Okay, kinesiology 230, chapter number 2 still. This is presentation number 5 out of 6. We're talking cardiac cycle, cardiac output. There's going to be a little bit of retread of information here to kind of support what we're talking about. So we have to have a little bit of a look back to be able to look forward. But without ado, let's get going. So the cardiac cycle, it consists of the events that occur from the start of one heartbeat to another. And this can be evaluated from R to R. It could be from the P to the P. But one concise, if you will, representation of a heartbeat would be from the P, the QRS complex, to the T. No electrical activity, P, QRS, T. So this represents one heartbeat. This represents one heartbeat, total heartbeat. Oftentimes, though, when we evaluate heartbeat and heart rate, when we're looking at ECGs, and also we start talking about different styles of training, we look at the R to R, and the R to R is this, the top of one R to the top of the other R. And it's this electrical activity that we see, and the QRS, when we talked about the amplitude in terms of the millivolts, it's where you have the greatest amplitude. And just depending how this looks, it can be insightful regarding different maladies that are going on in the heart. And I mentioned bundle branch block is one of them. Where you have a delay in response of electrical current. But for this, we're going to keep it real simple and keep it with a normal sinus rhythm, and then also normal QRS complexes. And the lower electrical activity is seen in the P and the T, obviously, because the amplitude is much less, because you can see the millivolts are much lower here than up here, right? Remember it's 0.1, 0.1. This is not even 1 or not even 0.1 millivolt, right? But what you'll oftentimes see is if you look at ECGs of people when they're in the hospital, this will look flat, or it might be hard to discern what is the QRX versus the P and the T, or the T is big and the P is small and vice versa. Optimal client, optimal condition. The representation you'll see here is this, and this is a little bit of tachycardic, but we'll let that go. But the long story short, you're looking at the R to R. Now, the cardiac cycle itself, we talked about this before. You have the SA node, and you have within the SA node itself, it's the pacemaker of the heart. And the P wave is the depolarization of the SA node. So you have the SA node and the P correspond to one another. The QRS complex is when these guys down here, the Purkinje fibers and the right and left ventricles contract because of the electrical impulse that comes down through the bundle branch to the Purkinje fibers. That's the QRS. So you can just imagine the amount of force it takes to squish that blood out to go to the lungs or go to the body. It takes a lot of muscle contraction. So if it takes a lot of muscle contraction, we're talking about what drives muscle contraction? Well, it's electrical impulse. Well, that's going to be recorded here with a much larger deflection in millivolts when the heart actually contracts. And then the T wave is the repolarization of the ventricle. So you have depolarization, squish, they contract. When they repolarize and they relax, that's when you see the T wave. So one whole heartbeat itself is a PQRST. Blood SA node depolarizes. The QRS is shown when these guys depolarize and contract and squish blood out. And then when they relax, that's the T. PQRST, PQRST, over and over and over. Now, what's interesting is, we look at blood pressure itself, and it's the amount of pressure exerted on the walls of the arterial and the vascular system. And when the ventricles depolarize, that's a QRS complex, the amount of pressure is the highest, right? We can kind of discern that just from our conversations, because you know that there's a lot of contractile force that has to happen to squish blood out to the lungs, deoxygenated, or squish blood out to the body, oxygenated, through the aorta to the rest of the body. And heart rate and blood pressure are both valuable tools in terms of being able to evaluate a person's efficacy or ability to exercise. And there's a difference between when you have ventricular depolarization and when the person is in repolarization, meaning in between heartbeats. The QRS, as we talked about, I'm going to go back one slide. The QRS is when you have depolarization of the ventricles, these guys down here, and then you have this kind of quiet time in between the T and the P, and that's after the repolarization of the ventricles, but before the depolarization of the SA node, which is this here. So if you think of it just in terms of what's happening mechanically, you know that there's a big fat contraction that happens here to squish blood out. That's going to give you the highest amount of pressure in the system when it's squirting blood out. Meanwhile, here will be the lowest pressure as the heart is actually resting or recovering in between beats. So when you look at blood pressure and you look at the blood pressure provided to the right, it's written in systolic over diastolic, S over D, however you want to remember it, higher over lower, and it always will be not 126 over 70, but it'll always be the higher number over the lower. What you see with this is it's 126 over 70. 126 is the amount of force squirt when the heart is contracting or during the QRS complex. The 70 is when the heart is relaxing. It's the pressure on the walls of the vascular system. When the heart is relaxing, that's in between the T and the P. So if we go, remember 126 over 70 here, if we go ahead and go 126 over 70, we go back here, where you'd see the 126 is here and here. The 70 would be seen right in here between the T and P. 126, 70. Squish, relax. Squish, relax. 126, 70, 126, 70. So it becomes a conversation of how these two are kind of intertwined with one another, right? So when you start to put this together in terms of the process, so we know the blood pressure and the ECG responses are kind of tied together. And when you have ventricular depolarization, you start to ask the question, knowing what you know regarding blood pressure and ECGs and ventricular, and by the way, sometimes it's written as EKG, not ECG, and that's why I slip up sometimes. But ECGs and ventricular depolarization would, the systolic side occur during the P wave, the QRS complex, or the T wave. So meaning, when you look at this, you have S over D, so the higher number is the 126. So it's S over D, it's the higher number over the lower. And would the systolic occur during the P wave, the QRS complex, or the T wave? And just based on what we just saw in a couple slides back, that it's during the QRS complex is when you have the greatest amount of pressure is exerted during ventricular depolarization, during the actual heart contraction, squish, which is the QRS complex on an ECG. Now, diastolic, it's more of an indicator of vascular stiffness, and the diastolic side, that lower number, stays pretty consistent. Even in an exercise environment, it won't raise as much as the systolic. You'll still have a little bit of elevation, but it's just not, on a percent basis, it's not as much as you'd see with the systolic. So where we have this, and we talked about this deoxygenated blood, et cetera, I'm going to just refresh this to kind of make sure it's in your brain. You have deoxygenated blood returns to the heart from the inferior and superior vena cava, hops into the right atrium. Remember, it's right because it's looking at the person's chest. Right ventricle out to the lungs via the pulmonary arteries. Takes blood away from the heart. It begins with an A, arteries away. Oxygenated blood, the red line, starts here at the lungs. As we bring oxygenated blood back into the heart, it's through, over here, the pulmonary veins. And this is where students sometimes get messed up, because you do have oxygenated blood that returns back to the heart via veins. And it becomes the pulmonary veins. Pulmonary for lungs, veins, blood is brought to the heart. So you have pulmonary arteries that take blood away from the heart to the lungs, pulmonary. And then you have pulmonary veins that bring blood back to the heart via veins. And again, this will be a question you're going to see somewhere, I can guarantee it. But that's usually where most people get tripped up, right? And it's going to be a test question somewhere, if not my class, somewhere else. So now let's kind of juxtaposition one by one, side by side. We talked about blood entering in the heart. Blood goes into the right atrium. The SA node, which isn't rendered here, but you'll see it here. The SA node depolarizes, that's your P. And then when the blood that is down here in the ventricles is squished out, it's squished out because the Purkinje fibers and the bundle branches contract to squish that blood. It's like a squishing ring almost, but it squishes the blood out both to the lungs, but also to the body. That's the QRS. It's the greatest amount of force. It's the greatest amount of electrical activity. That's why you see the greatest amplitude here. And then when these guys down here repolarize, that's the T. So again, with blood pressure, the highest blood pressure you'll see is in the QRS complex. The lowest blood pressure you'll see here, and this was represented in this presentation by 126, I think it was, over 70, 126 over 70. Got it? Moving on. So cardiac output is defined as the amount of blood pumped by the heart in 1 minute. And that's usually written as a Q with a little dot on top of it. A stroke volume is the amount of blood ejected per heartbeat. So every time we have that contraction, squish, it's the amount of blood that's squished out of the heart. The end diastolic volume, you got to kind of wrap yourself around systolic and diastolic, right? In terms of that terminology with blood pressure. The end diastolic volume is the volume of blood in the ventricles, right? These guys down here, after filling. With systolic, it's the volume of blood in the ventricles after contraction. And you know, let's think this through. If we go back to this, we know that you have systolic, diastolic, 126 over 70. You have blood is filling, blood is being squished out. Blood is filling, blood is being squished out. Blood is filling, blood is being squished, blood is being squished out. So when you look at this process that they're outlining over here, S over D. And if you want, maybe we can just rearrange these so it makes more sense. You have the systolic volume is the amount of blood in the ventricles after contraction. So at the end of systole, meaning the S part, the higher number, once it's squished the blood out, whatever is left is the end systolic volume. The end diastolic volume is the amount of blood in the ventricles after they've filled. So the difference you have is one is the filling of, and the other is the contracting and squishing out of. S over D. Hold on a second. Okay, I like that a lot better. S over D makes more sense. Like we've talked S over D through the entire presentation. I just quickly switched those. I'm going to try to remember to load this presentation up in the Blackboard so it matches. But yeah, it's the amount after contraction. This is the amount after filling. Just remember those two little pivot bullet points and you'll be okay. The Frank-Starling principle is this. It indicates that the more the left ventricle is stretched, the more forceful the contraction, meaning a greater amount of blood leaves the ventricle. So there's a mechanical principle to this in terms of the stretching of the ventricle that causes a greater amount of contractibility. And it makes kind of sense when you start thinking about muscle potential. We talked about potential energy versus kinetic energy. If it's stretched further, that rubber band, if you remember that, we shot that, it's going to have a more forceful contraction. There's going to be more force involved to go from potential to kinetic. So in a certain degree, you have this mechanical response where you've stretched the myocardium further, and that causes a more forceful contraction. All right, I'm going to break away from here. I'm hopefully going to remember to put that on the presentation in Blackboard. Moving on to the next one.